Okay.
And we have collaborated with the technical English. So I think we started the story around biosimilar. And so we can see of at the moment because we spoke so many times, sometimes together, and wrote so many review papers and analysis of this. We were a little bit smashed by the environment of biosimilars. But at a certain moment, because of that, in part, because of that, we stayed in contact. And another collaboration came with the COVID story. And really now, Vasco has invited João Gonçalves to speak about that. And the presentation will be not on biosimilars.
Not on biosimilars. All right.
So I guess
okay.
The command
can I have this? Okay. Okay.
Start a ligação automática. Okay.
So thank you. Okay, so thank you very much, João. It's
recording in progress.
Okay. Anyway, so thank you very much, João, for the introduction, and also Vasco for the invitation to be here and present some work we did last year in collaboration with João and Vasco about this question about on the immune response of the immune response of rheumatic patients for the vaccine, for the mRNA vaccine. So we, of course, where are the slides? Start the other one. Okay. All right. Okay. So of course, I mean, when we talk now about the immune response against the COVID-19 mRNA COVID-19 vaccine, of course, it's a bit delayed. I mean, everything went so fast that now we have this this project seems a little bit outdated, but at the same time, I think it still needs improvement in the way that we are looking at the immune response of patients, especially on immune suppressed patients, rheumatic arthritis patients for COVID-19 vaccine. So when we go for this, of course, going back, it's, I mean, when we started to present this last year, of course, this was like the first slide everybody wanted to know about the coronavirus disease and when it started and everything. So I think that there is still the need to understand not only the virus, there are many things that we don't know about the virus, but also how the immune response of patients in different settings. We are working in other cohorts of patients, hepatic diseases, etc. But I think that this immunomediated disease, like rheumatic diseases, is an interesting area because it allows us also to understand the disease by the immune status of the patient. And of course, now everything is stopped. Okay, at least that's what WHO says. But the idea here is really to present you some data that we have in a cohort that we collaborated here with the hospital and with the service of João Fonseca. So the idea then here is to understand a little bit and try to make an overview of the immune response, taking in consideration not only the symptoms, but also the risk factors that we have for the COVID-19. Of course, there are many risk factors that we know, and there is this intimate relationship between rheumatic diseases and also COVID-19 in terms of the immune factors that can stimulate the infection of COVID-19. So I think that immune-mediated diseases and how the immune system really gets to fight the disease, it's kind of a very similar environment or a very similar behavior compared to what we know with rheumatic diseases. So the idea of the virus, and when you look at the virus, basically we are always trying to look about the antibodies, what kind of antibodies they are produced, the humoral response. And I mean, for many months during the pandemics and even now, so we are still looking at the antibodies, but I think that we need much more than the antibodies and try to understand in terms of cellular response, in terms of the T cell response specifically, what is happening really with these patients. So this is, of course, we did all the work with the antibodies. We tried to characterize as much as we could the antibodies produced by the patients, by the array patients, and that's what I will talk about in a few moments. But anyway, when you look at the virus, what you want to have in a first stage, in the first instance of the vaccine, is really to produce antibodies that can inhibit the fusion of the virus with the cell. I mean, that's really what we aim for the virus, but we started to understand that probably the way that the cells might act might be also very interesting and very important. And specifically for the immunomediated diseases, trying to understand the response to the vaccines might be useful also to understand how the disease can be involved in terms of long-term suppression therapy. Of course, when you look at the immune response, we cannot eliminate all this innate immune response that we should understand. I mean, this question of the dendritic cells and plasmacytoid dendritic cells is quite important, and we don't have too much answers now still about these dendritic cells and how they respond to the COVID-19. We know that they are key in viral infections. They have excellent properties in phagocytic behavior. As you know, they serve as MHC class 2 presentation of antigens, but still we don't have too much information about that. Of course, the NK cells are also very important, and I think there is not so much data about that, specifically for rheumatoid arthritis patients and also for monocytes. Specifically for monocytes, we still don't have a good understanding how they might act in terms of this disease. So when you look at this immune response against SARS-CoV-2 and COVID-19 and these normal defenses that we have, and basically when we have like here an APC, antigen presenting cell, so we have this connection here with the CD4 T cell, and this production of interferon in a normal immune system is quite important and necessary. And here we have this CD4 T cell producing interferon, also have here the Th1 T cell helping the B cells. And of course, this is the normal environment that the immune system has to combat the viruses. So here, this is the normal way of having an immune system. But then when we go to this dysfunctional immunity that might happen in different immunomediated diseases, and that's one case is your patients. And actually, when we have that, we really have to understand that all this normal thing that we have on this side can really be separated then in a more Th17, as you know, Th17 axis of immune response here on this case, but also here on the question of understanding the memory T cells. But at the same time, you have this Th1 pathogenic Th1 cells. So at the same time, when you have this pathogenic Th1 cell, and also you have this increase of IL-6 that you see in this infection of with SARS-CoV-2, we have this cytokine storm that for the immune system gives opposite signals to combat the viruses. And this is the way that we think that things might happen in a different setting between a normal person and a person that has a defective or dysfunctional immune system. So in terms of immune inflammatory activities like in rheumatoid arthritis, of course, when you have this normal system that really makes this interaction with this synovial fluid here and all these cartilages. So what you see here is the immune system being activated and having this understanding of the immune system as I said before, with the pathogenic Th1, Th17 being more predominant. So it seems that there is some kind of similarity between what is happening in COVID-19 disease and rheumatoid arthritis. And the same when you go to this angiotensin converting enzyme dependent pathway, it seems that there is also this similarity between what is happening in a COVID-19 or in a SARS-CoV-2 infection, where you have this binding to the binding to this receptor here, the ACE2. And basically, when you have that, and also the binding here to this ATR receptor, you might have a good a stimulation here of inflammation that is basically the same that might happen in rheumatoid arthritis. So it seems there are some similarities in terms of how the immune system really fights, not so much fighting, but so the response of the immune system in patients to rheumatoid arthritis and to SARS-CoV-2 infection. So the idea here is really to understand, and when we approached João group in more than 1 year ago, the idea was really to understand if the immune system of an RA patient really, what is the behavior of those patients when they respond to vaccines? Because when you have a vaccine, you basically have just one antigen, and you try to improve the response on that. Specifically, when you have these patients here in immunosuppressive therapy. Of course, here on the immunosuppressive therapy, what is interesting is, I mean, some work has been done before understanding the comparison of this neutralizing capacity of patients with autoimmune rheumatic diseases without immune suppression, with and without methotrexate. And as you can see here, when you have this neutralization, and basically when you have a vaccine, what you're aiming for is neutralizing antibodies. And here, of course, when you have methotrexate, you probably have less capacity to neutralize the virus. And what is interesting here is also that posing methotrexate really improves the immunogenicity of COVID-19 vaccination. At least it was published before that. It seems that there is some connection between when you have methotrexate, you basically are down activating or down regulating the T cell activation, and probably this might be very important for that. And also there is this correlation between age and neutralizing capacity that is measured by what we have as surrogate virus neutralization test. I will show some data about neutralization of antibodies in our cohort, but basically when you look at the surrogate virus neutralization test, is not a full virus, is basically where we construct the virus, where we have different envelope proteins on the surface, and then we can use that as a surrogate virus neutralization test. And basically what you see here in this case of methotrexate is that the neutralization is reduced with the increase of the age. So also there is this data showing that there is this humoral immune response before and after the third and fourth booster of this mRNA vaccine from Pfizer, showing really that there is this, I mean, the fourth booster is really less potent than the third one. And this is really correlates with the presence of immunosuppressive therapy. So there is this relationship between the total immunosuppressive load and this amount of antibodies against the RBD, which is the tip of the S1 protein in SARS-CoV-2. So there is this proportion of better patients responding better to the vaccine when there is less immunosuppressive therapy. So the idea now, in the second part of the talk, what I would like to present you is the data that we had about this, some of the aspects of how the patients of your RA patients really responded to the mRNA vaccine, trying to understand how the humoral and the cellular response might be responding in terms of efficacy to the vaccine. So the question here is, the RA population really protected against the upcoming variants of concern? And this was last year, so you know that many variants of concern from Delta to Omicron, and then different variants of the Omicron. This was really one question that we had. And the second question was, if vaccination really promotes this equal humoral and cellular response, how this compares with the healthy subjects, with healthy persons. So we had also a cohort healthcare workers that we started 2 years ago in collaboration with different hospitals in Lisbon. And so we compare what happened in RA patients with what happened with those with that cohort. Of course, this is the vaccine. I will not give you any information of that. Everybody knows about this. But anyway, this is the study design. And basically, these patients were followed by you. I mean, by João Fonseca group, by Vasco. And here we have this baseline, T0. We have the first immunization. We had this first sample, T1, 1 week after first immunization. Second immunization, we had it after the T1. And then we have different time points where we got the samples, okay, until we have this 6 months after the first immunization. So this was after the first immunization here, not the second immunization. So anyway, so this was the number of cohorts in this study. We had 82 RA patients, 53 healthy controls, but we had some withdrawals from the study. Some of them got infected, and some of them really we didn't have the sample was not in a very good quality, so they were withdrawn from the study. So this is basically that. So at this time, and still we are looking. You probably are going to ask about the therapy of these patients. This is a more clinical part. I have to confess that I don't have that data yet. We are still working on that data, but I'm sure this will come afterwards. So the idea is that what we have done in terms of methodology, this is for the humoral response. So we did a lot of these ELISAs that you have seen around, but also we did a new neutralization test. It's more a rapid neutralization test, a surrogate neutralization test, where we used a virus that is connected with a fluorescence. So it was very easy to understand how the virus really binds to the cells and how the antibodies interfere with this binding and fusion to the cells. So this was a very interesting methodology, really to rapidly, in a couple of days, really to evaluate the neutralization of the immune response. Of course, when we look at the antibody response of this of the SARS-CoV-2, and here we have against this is the original strain. Okay, so this is the response of anti-S1, IgG, and IgM, and this is the RA patients in red, and here in blue there is these healthcare workers. And what you see is that, of course, the healthcare workers were very rapid in terms of response over the different time points. But actually, what is interesting here is that the IgM that we were measuring was almost similar to the healthcare workers. And actually, there was this waning of the antibodies, as you could see here. At 6 months, we are reducing the titer of these antibodies. So there was this delayed response that we had for that response. For the Delta and Omicron, and we did several variants of the Omicron, we have seen the same kind of response. So it seems that this confirms what has been also published, that we have a less response of the immune in antibody response, both at the IgG and IgM, but in this case is IgG, showing that there is this delayed, but really at the end of the day, at 6 months, you see that the titer of those antibodies and the amount of those antibodies, and actually we don't measure the titer. I think there is a lot of discussion. What is important is the titer or is the concentration of the antibodies. The titer does not give you a good understanding of the strength of this immune response. So there is this delayed response in RA only after the second dose. And of course, we have a better response to Delta and Omicron in healthcare workers more than RA, but I'm sure that at the end, we'll get the same immune response. For IBD, in terms of neutralization, so we did the neutralization effect, and if you see here the response of the response of IgG in terms anti-delta and Omicron in array and in patients. This is the binding antibodies, but when you see the neutralizing antibodies, you see basically the same. But what is interesting is always at the third time point, you see this equivalence of the amount of antibodies that the patients with array is producing, and then it will decrease the same as in patients and healthcare workers. So there is this neutralization activity that, although the amount of antibodies is low, the neutralization activity in RA patients is very good, and actually it goes to the same level of neutralization as you see in healthcare workers. Okay, so this is really what we got from this comparison that we had in terms of antibodies, and the conclusion, the first conclusion we take is that the amount of antibodies is lower. I mean, we see less amount of antibodies. This is less production of antibodies. It seems that the B cells are not really activating and producing a large amount of antibodies, but then the quality of those antibodies are very good because you see this neutralization effect here. The same that we got for Delta and for Omicron. So this is not specific. This is not specific just for the original strain, but this is also comparable, and it is comparable to the Delta and Omicron. It seems then that we have this and this capacity at the third time point really to make an equivalence in terms of neutralization. So really the kinetics profile here between the patients and the healthcare workers' normal immune system is that it is very similar at the third time point. So then we went to the cell-mediated immunity. And the idea here was trying to evaluate what might happen in terms of T-cell response and non-T cells. And here on non-T cells, of course, we are looking for the B cells and also for the innate immunity. So we try to understand as much as we can from the samples that we got. It's understood that in the amount of sample that we got was not very much. So we tried to make a panel here that was the most understandable as possible. But anyway, we tried to understand what might happen in terms of CD4 T cells for the central memory and the effector memory. So I think this is interesting to see what is happening in terms of sustainable and non-sustainable response to the immune to the vaccine. I think this is a good question that we might have. The same for CD8 T cells, okay? The same for CD8 T cells in terms of central and effector memory. We also try to evaluate here the NK cells on this side because we try to see if there is an imbalance in terms of activation of NK cells, and also the B cells because we are seeing this production of low amount of antibodies, but also a good quality of those antibodies. And this is quite interesting because then we might have here this help from the CD4 T cells to the B cells. So this connection between the CD4 T cells and the B cells might also be interesting to evaluate. So when you look at the innate immune system, when we compare the T0 with the T3, and when we look at the natural killer cells, what we see here is that we see a reduction when we compare the number and the percentage of live cells that are natural killer cells. Usually what we see, and this is sustainable over the many experiments that we did, is that there is a decrease in the natural killer cells. Specifically, these terminal natural killer cells. It seems that the patients really don't respond in terms of NK cells. They don't respond at high level with the terminal killer cells. In terms of plasmacytoid dendritic cells and monocytes, we have not seen a big difference comparing to the normal immune system and an array patient. And here is what we try to evaluate. In terms of B cells, what we have seen basically is kind of an interesting point here, is when you look at this IgD plus B cells, meaning that those cells that produce IgM in large quantities, comparing this to CD4, I'm sorry, here it should be here, IgG minus. So it seems that we have a high production, high number of cells here that correlates with the amount of IgM, higher production of IgM that you might have here. Of course, when you have IgD minus, you don't see that so much in patients. And this is quite interesting to understand that there is this difference in terms of production of these cells. In terms of switched memory B cells and non-switched memory B cells, we have not seen really this difference that might explain what is happening here on this case. So this remains to be evaluated, why the patients, they have this large amount of IgD plus cells that produce IgM in large quantities, but we don't see this non-switch memory cells being increased. It means that probably the memory cells are not very effective on this case. So basically, this is the preliminary conclusion here on for the RA patients. We see more of these cells and less on the healthcare workers. I mean, this was already published before, but this is just for you to understand that, for example, published data show that patients, the MS patients treated with an antibody against CD20, they really have less memory B cells, and also they produce less antibodies. This is just to confirm that what we have seen probably might happen in RA patients. In TCD4 differentiation, what we have seen here is an interesting point, is that when you have these T cells and you separate them in CD4 and CD8, and then you go to analyze the naive CD4 cells, central memory, and effector memory, what is interesting here is that we have if you compare here T0 from T3, T0, T3 here on RA patients, you see a reduction, a dramatic reduction in the effector memory CD4 T cells. It seems that the sustained response in RA patients is probably not so much effective as in normal normal immune system. So this question might be related to the fact that then you might have less stimulation of the B cells. So all the other variables are okay. In terms of CD8 differentiation, we don't see that. And actually, you see a little bit of an increase. We need to do more samples here, but probably we see more this difference between the central and effector memory. We don't see this decrease as we have seen in CD4 T cells. It seems that there is this stimulation of the effector memory T cells that might help then the sustained response for the vaccine. So we have done this naive CD8 T cells, central memory effector, terminal effector memory T cells. And here also, we have seen this increase. It seems that the patients, the RA patients, they probably compensate what is happening B cell, what is happening CD4 T cells, they compensate that with CD8 T cells. So this is the conclusion for the RA patients. So the second conclusion probably here is that we might have this CD8 T cell response more exacerbated in RA patients. Of course, this is a little bit the opposite what we were expecting for a normal person. Okay, so this is what we expect for a normal person: high number of CD4 T cells, higher number here of CD4 TFH cells to help the B cells. We were expecting to have all of this increased in RA patients, but it seems that we don't have that. So it seems that in RA patients is the opposite: less TCD4 memory T cells and higher CD8 T cells. And the last part is just to show you that we have stimulated these cells with peptides of the virus. Okay, so the idea is not just to count the number of cells, but also to see whether the phenotype of these cells in terms of response to peptides, response to the virus, really is improving when the patients are vaccinated. So what we have done basically is to measure interferon gamma. I mean, we put the cells from your patients, we put the cells, and then we stimulate with different peptides or cocktails of peptides from the virus. MHC class 1 or MHC class 2 peptides, and then we try to see whether they respond to the peptides with the production of interferon gamma. And basically, this is the total response that we had. Basically, the patients, although they have CD8 T cells, stronger response in effector memory, the type of response is not so high as we have seen here for the production of interferon gamma. And basically, if you look here at the time at T4, when we have this response of the interferon, basically almost of the patients, they respond in terms of cellular response and immune response, but the type of response is not probably the best. This is just an example. What we did later was to see whether these cells might be producing cytokines in response to the peptides. This is just an example of a cytometry. So we want to analyze interferon, IL-2, TNF, and when we try to analyze the expression of these cytokines when they are stimulated by the peptides. And basically, just to make a long story short, if you see here the frequency of CD4 T cells on your patients, and you see here the combination of these three cytokines here, it is, I mean, the type of response of the RA patients is also always less than the healthcare workers and the normal immune system. So it seems that there is this, this is, I'm sorry, this is not CD8 T cells, this is CD4 T cells. This really confirms what we have seen before with the numbers that we had in terms of cells that we are counting for TCD4s. And basically here, when they don't respond in CD4, they don't respond so well as the healthcare workers, specifically here in IL-2. It's amazing that we don't see expression of the TCD4 T cells of every patients when they are activated by the peptides. So there is this, we don't know why. I mean, it's interesting to understand why they don't really respond with IL-2 when they are stimulated with the peptides. So this might correlate then the quality with the amount of TCD4 T cells in those patients. We also did this correlation of anti-S antibody level and spike-activated CD4 expressing interferon gamma. There is this, the correlation is not so good between T3 and T4, but we have this good correlation here in healthcare workers. So there is this lack of correlation between the expression of antibodies and the cellular response. And this is the last part of the work. And then we try to understand, and using tetramers here specific for type 1 and type 2 type 1 and type 2 response. You see here the different HLAs, and here the peptides and these are peptides. I have to say that these are peptides from the original strain, but they are very conserved in terms of Delta and Omicron. So basically what we did, we used this, tetramers, and tetramers are HLAs, proteins, HLAs, that are binding to the peptide, okay? So we have this bit, and this bit, they have like HLA, these different HLAs here on the surface, and in a multimeric fashion, okay? So, and then these HLAs are binding to the specific peptides that you see here. Why this is interesting? Because then you can map which cells are really stimulating, producing TCRs that really respond to this tetramer. And then you can see this by flow cytometry. So the localization of peptides that we use, this is the S1, S2, S3. So this is the S1 protein, S2 proteins. I'm sorry, this is probably not very, it's not a good thing here to show S1, S2, but this is the type of peptides that we have. So we have these different peptides here for the S protein and also for the nucleocapsid protein. So then we stimulated this, okay, on the patients. It compared the healthcare workers with RA patients. And this is to make a long story short here. Basically for the CD8 T cells, it's very comparable between all of these peptides that you have here, very conserved here for the S1 protein. And then we also did the nucleocapsid. For the CD8s, this is very comparable between the healthcare workers and the RA patients. So the CD8 T response, CD8 T cell response is very similar. You almost don't see the difference between the expression and the recognition of HLA peptides. But when you look at the CD4 T cells, there is a difference here. Okay, so this is another confirmation showing that these patients, your RA patients, they don't respond the same way in terms of TCD4 response. And this is the final conclusion of an hour. I think it was what you were asking. Anyway, so basically, to make a long story short, and just 2 or 3 conclusions here. Of course, RA patients, they have this robust cell-mediated response. They try really to compensate what is missing in terms of CD4 to CD8. They have this impaired delayed quality of antibody response. But anyway, the neutralization, the capacity of neutralization is very high at the medium term comparing to healthcare workers. So this neutralization really does not differ between affected and non-affected individuals, although these seroconversion rates are lower in the individual with RA. And actually, this conclusion is quite in agreement with results that although the RA patients treated with rituximab have this lower humoral response, really the cellular response in those patients with rituximab is quite strong compared to what we have in normal people. So this is the final conclusion. Of course, in RA patient, there is this divergent dynamics of humoral and cellular immune response. And there is, of course, there was no difference in seroconversion. That's what we have seen. The seroconversion and that correlates quite well with neutralization, although this concentration of antibodies is quite different between the two populations. And this ability to generate a sufficient immune response really is important for really protect the patients in terms of further infections with SARS-CoV-2. And this is just to acknowledge my group, and of course here, the group of João Henrique Fonseca, Vasco, and Dr. Matilde Bandeira. So thank you very much. If you have any questions, just please ask. Thank you.
I'll try to use the microphone.
I can borrow yours.
But anyway, just before the questions, just to remind that in fact the slight differences in terms of immune behavior is not only related to the deviation from standard of rheumatoid arthritis immunology, but also the standard of care that they are being submitted to. And in fact, it's a little bit of looking at the reality. So rheumatoid arthritis patients are like this. So they have their immune system that is a little bit disturbed by the disease. And most of them, or at least ideally all of them, are submitted to a standard of treatment that will have impact also in the immune system, because by definition, we want to impact the immune system to control the disease. So this is a little bit looking at a bombed city by the treatment, but anyway, it's the reality. So is there any question that you would like to put to Professor João Gonçalves? Elsa?
Well, first of all, thank you for the presentation. I'm curious about the 7 patients that got infected with COVID. I admit this was between the time points of the collections. Do you have any data? Did you look at the data from the infected patients?
Yes, we have it. We have not shown that because this will disturb completely we have a much more higher response in terms of CD8 T cells. CD8 T cells. So yeah, they go high comparing to the other numbers. So that's why we took them from the analysis, because this might. But really, the patients, you see, those 7 patients we have seen higher cellular response compared to the non-infected. So it seems that I think there is this presentation of class 1 antigens that might stimulate the CD8 T cells.
Thank you.
But we don't have too much data on that.
Yeah.
We have seen.
And there are just 7 patients.
Yeah.
Maybe Vasco wants to comment about the experience that we had with this project.
Yes, thank you. So one, there is some, I think, some additional question which you mentioned, which is the treatment. But I think we're still looking at that, right, in terms of which patients were doing which treatment, and especially rituximab, because I knew we had some on rituximab, but do you have any preliminary data on that? No.
Yeah, we have to work together on that.
Okay.
So trying to see from this what is really rituximab. But
Okay.
we have not seen kind of two populations
Okay.
that might
Mhm.
indicate that you probably have like 2 different populations there on the cytometry that might indicate differences in treatment. So we see everything is quite conserved in terms of the type of response. So I don't see that. I'm not sure what therapy you are using in patients, but of course some of them will be rituximab, but I don't see the differences there.
Okay, thanks.
Just making the bridge to the clinics. I'm just remembering Professor João patient, an RI patient that was in remission for many, many years and without any treatment. And she just got COVID and she had a high flare of the disease. So we all know that viral infections can trigger the disease. But in this case, this patient was really without treatment for many, many years and she got infected. And after that, she has been with high disease activity. I don't know if you remember this patient, but
interesting.
Yeah.
Yeah, that's interesting.
Just
Yeah.
bridging.
I mean that there is this report saying that there is this connection between infection and high probability of. It's probably not the high probability of infection. It's probably the patients of array that probably are flaring or increasing the immune response. So we don't know what might be the cause, but anyway, what we see is that there is this, at least in CD8 T cells, but I'm not sure if the response of this patient is a T cell or B cell mediated.
No one studied.
Anyway, so it's difficult to see what kind of flare is that.
But I can ask Vasco to recruit her.
Okay. Okay. Anyway.
Any more questions?
Okay.
Okay, if not, thank you very much again,
Thank
João.
you.
Thank you very
Obrigado.
much. Coffee breaks, but eu penso que temos coffee break lá fora. We have a coffee break outside, I think.